Hello, I'm Umar Khalid. I'm one of the social media editors at JACC Cardiovascular Interventions, and it's my great pleasure to welcome Dr. Marquardt for this interview. Thank you so much for joining us today, Dr. Marquardt.
Of course, of course.
So today we will feature your publication titled Percutaneous Coronary Intervention in Multivessel Disease and Infarct-Related Cardiogenic Shock, a DanGer shock substudy. So, Dr. Marquardt, could you please begin by describing the design of the study for the audience and how does it differ from the prior work such as culprit shock?
Yes. So the study is a sub-study of the DanGer shock trial, which included non-comatose STEMI patients complicated by cardiogenic shock. This sub-study focused on patients with multivessel disease and how these patients were treated according to PCI strategy. So the trial itself included patients with cardiogenic shock and STEMI, but the patients should have a lactate above or equal to 2.5, a left ventricular ejection fraction below 45, and a systolic blood pressure below 100 or use of vasopressor. So that was the definition of the shock population. And then in this sub-study, we only included patients with multivessel disease. And to talk about the differences between the culprit shock trial, this study only included STEMI patients, whereas the culprit shock study included non-STEMI patients as well. Also, the culprit shock patients were, I think it was 54% of them that were resuscitated from cardiac arrest. And in the DanGer shock trial, patients were non-comatose, all of them. In comparison to the complete trial, which is a trial investigating PCI strategy in hemodynamically stable patients with multivessel disease, none of them had cardiogenic shock, even though it was not an exclusion criteria. The trial did not include cardiogenic shock. And that also, and the trial also consisted of non-STEMI and STEMI patients. So this is a pure STEMI cardiogenic shock cohort that we investigated the PCI strategy in.
Thank you so much for going over the design of the paper and also how it's different from the other papers such as culprit shock and the complete trials. Now, on that note, could you go over the results of your analysis?
Of course, of course. So, of the DanGer shock trial cohort, 221 patients had multivessel disease. And in these patients, we overall saw that the groups between immediate multivessel PCI and culprit only PCI group, they were well balanced in general in terms of the baseline characteristics. And but we saw that the immediate multivessel PCI group, they had a significantly lower odds of all-cause mortality at 180 days compared to the culprit-only PCI group. Moreover, we saw no association between immediate multivessel PCI and acute kidney injury. And we saw no interaction between, or according to the randomization allocation and the PCI strategy. So the positive effect that we saw from the main DanGer shock trial of the microaxial flow pump was not modified by the PCI strategy.
Excellent. Thank you so much for going over the results. Now, one thing I noticed was the adjusted odds ratio of 0.4 that suggests a very striking mortality reduction. So in your opinion, do you think this is because of the hemodynamics, reduced ischemic burden, or any other mechanism? What do you think?
So of course we can't exactly see what the say what the mechanism is or the exact mechanism, but it may be due to the improved hemodynamics due to the secured blood flow in the non-culprit territories, which are exposed to ischemia. So we lower the overall ischemic burden, which may improve the performance and the recovery of the left ventricle. And by preserving the perfusion of all non-culprit territories, we may help the left ventricle to recover, and thereby securing the function of the ventricle, which may be of even higher importance in hemodynamically unstable patients compared to hemodynamically stable patients. But we of course have to be a little bit cautious with the interpretation of this, as it was not patients were not randomized to the PCI strategy. So this
Absolutely.
is a post-hoc study.
Yes, no, that makes a lot of clinical sense. Thank you for your answer again. And lastly, culprit shock, if you look at the trial, it in a way discouraged immediate multivessel PCI, and your results seem to suggest the opposite. I know you discussed about some of the differences, but do you think it's the patient selection, use of mechanical support, or something else, in your opinion, that might explain this discrepancy?
Yeah, so we touched a little bit upon the differences between two trials to begin with, but definitely I think it has something to do with the patient selection. So compared to the culprit shock trial, the DanGer shock trial consisted of an LV dominant cardiogenic shock cohort. So these patients may be more cardiacally ill, because they only consist of STEMI patients, and they also had lower TIMI flow compared to the culprit shock trial patients. Moreover, they had a higher lactate level in the DanGer shock trial. So 34% of the culprit shock trial patients had a normal lactate level. So there are key differences between the two trial populations that may determine the outcomes. But we also have to point out that a lot of the patients in the culprit shock trial, they were randomized to complete revascularization, where this study investigate immediate multivessel PCI. So that is not necessarily complete revascularization. So the attempts, for example, at CTO lesions were very low in our sub-study compared to the culprit shock trial. So there are key differences that may be crucial for the outcome between the two trials. And also in culprit shock trial, they randomized patients to this PCI strategy, whereas
right.
In this sub-study, it was a sub-study which was post-hoc, so they were not randomized to the PCI strategy.
Perfect. No, thank you so much for highlighting all these differences between the two trials, which really help us interventional cardiologists to use this data in our clinical practice. So, and then thank you again for joining us today, and congratulations on your work, Dr. Marquardt.
Thank you.